Hello and good morning to all of you. And our today's topic is tubular function in the renal system. This is one of the most important topics of the renal system after the ac- no, glomerular functions. Tubular functions are the most important one. Okay. So seeing the situation, the how you can say that this is the most important topic because you understand the composition of the blood or the internal environment of the blood is determined not by what the mouth ingests but by what the kidney keeps. So you can understand how kidney is important in maintaining your internal environment or for the homeostasis. Okay. Now, the functional unit of the kidney is a nephron. Okay, it consists of blood vessels and urinary tubules. Blood vessels are the afferent arteriole, glomerulus, efferent arteriole, and peritubular capillaries. Coming to the urinary tubules are the Bowman's capsule, proximal convoluted tubule, loop of Henle, distal convoluted tubules, and collecting duct. The three basic renal processes are glomerular filtration, tubular reabsorption, and tubular secretion. Now, before discussing the important portions, there are some general considerations we have to take care. And that is what is secretion and reabsorption. These two words you will be hearing mm, too many times. So, how do you understand the difference between secretion and reabsorption? They are basically transport of solutes in two different directions. Okay, secretion is transport of solutes from the peritubular capillaries to the tubular loop. By secretion, there is addition of substance to the filtrate. Example: potassium nitrate and hydrogen. And what is reabsorption? Reabsorption is active transport of solutes and passive movement of water into peritubular capillaries from the tubular lumen. This means that it is removal of substance from the filtrate. So example is sodium reabsorption from ECT. You can see that this is the glomerular filtration. From the glomerulus, the filtrate is coming to the tubular lumen. Okay. And removal of solutes from the tubular lumen and then coming to the peritubular capillaries, this process is tubular reabsorption. While if the solute is coming from this peritubular capillaries to the tubular lumen, the process is known as tubular secretion. The only difference is the direction of the movement, and it is not that means means that is both the process is responsible for main, uh, maintaining the urinary constituent. Okay, and why we are using reabsorption? Why not only absorption? Because the first absorption is taking place in the GIT. Okay, when the solutes are already these solutes have already been added to the bloodstream. Now this is the second time you are adding the solutes to the bloodstream. So this is reabsorption. Okay. Now coming to some formulas or you will be learning in this portion. The filtered load. What is filtered load? The amount of solute transported across the glomerular membrane per unit time. Means we are talking at the level of glomerulus. What is the filtered load of that particular solute? GFR multiplied by plasma concentration of the solute. Okay, it is ml per minute multiplied by milligram per ml, and it will be coming about milligram per minute. Okay, the excretion rate, amount of a substance that appears in urine per unit time. Here urine flow rate is multiplied by urine concentration of substance, and that also is milligram per minute. Now the important thing, renal tubular transport maximum of a particular solute. This means the maximal amount of a given solute that can be transported, reabsorbed or secreted per minute by the renal tubules. It is measured in milligram per minute. Now there are some exceptions to these formulas. Exceptions are uric acid, and this is an organic substance, and potassium, which is an inorganic substance. These both substances are both reabsorbed and secreted. Some solutes have no upper limit of transport, hence no transport maximum. The rate of transport is determined by electrochemical gradient and renal tubular flow. So, the more and more of sodium is coming to the coming to the tubular lumen, more of sodium will be reabsorbed. Okay, so these two solutes don't have any transport maximum. Reabsorption of sodium along the nephron or secretion of potassium by DCT has no transport maximum. Now, what is the threshold concentration? The plasma concentration at which a solute begins to appear in urine. It is a characteristic property of that particular substance. Okay. Now coming to tubular reabsorption. All plasma constituents except the proteins are indiscriminately filtered together through the glomerular capillaries. In addition to waste products and excess material that the body must eliminate, the filtered fluid contains nutrients, electrolytes, and other substances that the body cannot afford to lose in the urine. So, there is tubular reabsorption. This tubular reabsorption is a highly selective process. All constituents except plasma proteins are at the same concentration in the glomerular filtrate as in plasma. So you understood? The tubules have tremendous work to filter out or reabsorb the solutes and excrete only the unrequired and take up all the nutrients that is required. In most cases, the quantity of each substance is the amount required to maintain the proper composition and volume of the internal fluid environment. Variable reabsorption is done depending on the need of the body. Okay? Of the 125 ml per minute filtered, the GFR, you understood? Of the 125 ml per minute filtered, typically 124 ml per minute are reabsorbed. Considering the magnitude of glomerular filtration, the extent of tubular reabsorption is tremendous. The tubules typically reabsorb 99% of filtered H2O. This means about 47 gallons per day. Okay? 100% of the filtered sugar or 2.5 pounds per day and 99.5% of filtered soda. So understand the tremendous amount of work that tubules are working day and night. Okay. Now, what is tubular reabsorption? It is a transport of solutes from the tubules to the peritubular capillaries, and this involves transepithelial transport throughout its entire length. The tubule is one cell thick and is in close proximity to a surrounding peritubular capillary. Adjacent tubular cells do not come in contact with each other, except where they are joined by tight junctions at their lateral edges near their luminal membrane, which face the tubular lumen. The tight junctions largely prevent substances from moving between the cells. So materials must pass through cells to leave the tubular lumen and gain entry to the blood. There is no transcellular movement. Interstitial fluid lies in the gaps between adjacent cells, that is, the lateral spaces as well as between the tubules and capillary. The basolateral membrane faces the interstitial fluid at the base and lateral edges of the cell. See, you can see this is the tight junction and it is present toward the luminal surface of the cell. And furthermore, there is no contact in between the cells. The basolateral membrane and the edges are surrounded by the interstitial fluid. Okay. So you can see the direction of the solute movement from the tubular lumen. It is going into the cell. From the cell, it will be delivered in the interstitial membrane via the basolateral membrane or the lateral membrane, and from the interstitial fluid the solutes are absorbed to the peritubular capillaries. The absorption of the solutes from the lumen to the tubular cells is usually a passive movement, or you can say it is a collateral transport. But from the cells to the interstitial space, the there is a use of energy. Okay, so you will observe that basic use of energy is moving the solutes from the cells to the interstitial space. Okay. Now, how there are various methods for renal transport mechanism. The methods are pumps, carriers, and channels. The transepithelial transport. Okay, every transport via the tubular cells is a transepithelial path transport. Transepithelial transport is of two ways. Either it is a transcellular pathway or paracellular or intercellular pathway. Transcellular pathway is passage of a substance from the tubular lumen to the interstitial fluid through the tubular cells. About two-thirds of sodium transport is active and transcellular. What is paracellular pathway? This follows the lateral intercellular spaces. About one-third of NaCl transport is passive and paracellular. This you will be seeing in the next slide. Now, this transcellular pathway, it can be done by three ways. Either there is a pump, or there is a carrier, or there are channels. The pumps are the primary active transport processor. Basically, sodium potassium ATPase pump present on the basolateral membrane of PCT or carriers represent the facilitated diffusion and secondary active or carrier mediated transport. What about channels? These represent diffusion, transport of sodium across the tight junctions of PCT along with chloride. This is diffusion. See, you can see the movement of the solute from the tubular lumen via the tubular cells to the interstitial space is a transcellular process, while the movement of solute across the tight junction, this is paracellular movement. Now, coming to transport in different segments. So, what are the segments? The segments are PCT, loop of Henle, and DCT and PCT. What is PCT? PCT is proximal convoluted tubules. Proximal convoluted tubules, these are these have the major brunt of absorption of solute, or maximum absorption is done in this portion. What it reabsorbs and what it secretes. It reabsorbs 70 to 85% of sodium, chloride, bicarbonate and water. Almost 100% of potassium, phosphate, amino acids and glucose. And what it secretes hydrogen and end products of metabolism and harmful drugs and toxins. Coming to loop of Henle is divided in three portions: thin descending segment, thin ascending segment, and thick ascending segment. Thin descending segment, this portion is highly permeable to water but relatively impermeable to solids, especially NaCl. So 5 to 10% of water gets reabsorbed in this portion. Thin ascending segment is impermeable to water but permeable to NaCl and urea, and here there is passive reabsorption of NaCl via the tight junctions. Thick ascending segment, it is impermeable to water and solutes, but it actively reabsorbs NaCl by sodium potassium pump and sodium chloride potassium importer. Okay, about 20 to 25% of NaCl, about 20 to 25% of sodium, chloride and potassium are reabsorbed. What about the distal convoluted tubules and the collecting duct? These two reabsorbs about 5 to 20% of sodium, chloride, bicarbonate and water, and it secretes sodium, potassium and hydrogen via competitive exchanges in exchange of sodium and bicarbonate. Okay. Now, coming to our main topic of study, we have to study the transport of glucose sodium reabsorption, bicarbonate reabsorption, potassium transport, hydrogen secretion, chloride transport, and water reabsorption. So we have to study 1 by 7 portion, and in this class we will be covering only to the glucose and sodium reabsorption. Next 5 we will be covering in tomorrow's class. Okay. Now coming to glucose reabsorption. Glucose is completely reabsorbed from the tubular fluid in the proximal convoluted tubule. It is reabsorbed along with sodium from the tubular lumen. Now the sodium is pumped out of the tubular cells by the sodium-potassium pump in the basolateral membrane, but from the lumen to the or from in the luminal membrane, the sodium and the glucose is transported via a carrier protein known as sodium glucose cotransporter. See, this is the sodium glucose cotransporter. The process is a typical example of secondary active transport. Why? Because the absorption is coupled with the sodium-potassium ATPase pump present in the basolateral membrane. The sodium which is absorbed from the luminal membrane coming to the tubular cell is excreted to the interstitial fluid with the help of the sodium-potassium ATPase pump. This creates a sodium deficient area or decreased concentration of sodium in the tubular cells. Decreased concentration of sodium helps in absorption of sodium, and along with the sodium, glucose is also being transported. The transporter on the luminal membrane is SGLT1 and SGLT2. Now, the glucose which has been absorbed via the luminal membrane is coming to the tubular cells and then being excreted to the interstitial fluid by the transporter called loop 2. Glucose is transported into the interstitial fluid from the tubular cell by the loop 2. Glucose reabsorption is closely associated with sodium reabsorption. Okay. Now glucose is filtered at a rate of 100 milligram per minute. How you came to this for this? You know that normal plasma glucose concentration is about 80 milligram per dl and GFR is 125 ml per minute. So the the filtered load is about multiplying the normal plasma concentration to the GFR, and this comes to about 100 milligram per minute. Almost whole of, please do consider the unit while multiplying these two. Okay. Almost whole of the glucose is reabsorbed, making urine practically free of glucose. Rate of glucose reabsorption is proportional to the amount of glucose filtered, and the glucose filtered is proportional to the amount of the plasma glucose level. Thus, plasma glucose level determines the transport maximum for glucose. Normal transport maximum is 375 milligram per minute in males and 300 milligram per minute in females. Now, what is the renal threshold? Renal threshold is transport maximum divided by GFR. This comes to about 300 milligram per dl. Please consider the unit whenever you are multiplying or dividing anything. Okay, then only you will be coming to the answer. But the actual renal threshold is much below the predicted value. The actual curve deviates from the ideal curve. This deviation is called the renal splay. The splay is because of two reasons. What are the reasons? The reason is transport maximum is not the same in all the tubules and amount of glucose removed from each tubule is not complete. Okay. See, you can see the graph. This is the filtered load, and what is the reabsorbed? This is the reabsorbed. This deviation, this deviation from the filtered load and the reabsorbed curve, this is the renal splay. Okay. Please give the answer what is renal splay while you are giving your attendance. Okay. Protein reabsorption. Now coming to protein reabsorption. Proteins usually don't appear in urine as they are totally reabsorbed in PCT. About 7 gram of protein per day is filtered by the glomerulus. This is a very minimal amount of protein that is being filtered by the glomerulus. Usually proteins is not being filtered, but what is being filtered is about smaller proteins, that is about 7 gram per day. Secondary active transport is responsible for reabsorption of amino acids by the PCT. Now these proteins which are being coming to the tubules are being absorbed by the tubular cells along with sodium by a transporter. Similar type of transporter that is absorbing the glucose. Here also the proteins are absorbed by the tubular cells along with the sodium. The proteins are degraded by the cellular enzymes into respective amino acids, which in turn are transported to the blood via the interstitial spaces. But when the amount of filtered protein is more than the 7 gram per day or more, then proteinuria occurs. So, if there is protein, if you came to know there is protein for it, then you have to suspect there are two sources of protein in urine. First of all, when there is excess filtration followed by less reabsorption in PCT. Why there will be more filtration? Usually excess of filtration occurs only when there is damage to the glomerular membranes, and that condition is known as glomerulonephritis. Okay. But in normal condition, when there is no glomerular nephritis, then also some proteins are present in the urine. Proteins synthesized by the cells of thick ascending limb of loop of Henle are excreted and are called as dam horsefall protein. So why these proteins are coming in urine? Any answer? Because protein reabsorption process is present only and only in proximal convoluted tubule, and these proteins are synthesized in the thick ascending limb of Henle and After the PCT, there is no mechanism for absorption of protein, and so the proteins secreted by the thick ascending limb of Henle will be coming to the urine, and so you can see the protein in urine. Okay. Now sodium reabsorption. About 98% of the energy utilized by the tissues are utilized for sodium reabsorption. By this, you can understand the magnitude of the sodium reabsorption and the importance it keeps in the tubular function. So the filtered load of sodium is about 575 to 580 gram per day. Approximately 98% of sodium is reabsorbed, of which 60% is reabsorbed by PCT, 20% by thick ascending loop of Henle, 15% by DCT, 2 to 3% by convoluted tubules and collecting tubule, and the remaining 2% is excreted. 75% of reabsorbed sodium is accompanied by chloride and 25% by bicarbonate. We will be studying sodium reabsorption in three stages. Three stages means maximum sodium reabsorption takes place from PCT, about 60%. 20% by thick ascending loop of Henle, and 15 to 18% is reabsorbed from DCT and CT. See, you can see the absorption method. About this is the sodium absorbed via the channels. This is the sodium absorbed along with the glucose by the symporter, and some of the NaCl is absorbed along with water via the intercellular space. Okay. In this picture, you will be seeing that various processes at various different sites are responsible for absorption. See, in the PCT, sodium is absorbed along with the glucose via the glucose transporter. Okay. And this is the example of secondary active transport. Okay. Sodium is reabsorbed along with the glucose via the symporter. The sodium coming to the tubular cells is then transported to the interstitial fluid via the sodium potassium ATPase. Okay. First, sodium undergoes passive co-transport with the secondary active transport of glucose or amino acid via the symporters. Next, what happens? Sodium reabsorption occurs coupled with hydrogen. There is also coupling of sodium along with hydrogen secretion, that is via the sodium hydrogen exchange. The transport of sodium in the PCT is not associated with potassium secretion. Okay, in the PCT, sodium is not coupled with potassium. Now, to maintain the electroneutrality in the tubular cells, excess of sodium has entered into the tubular cell. This is maintained. This electroneutrality is maintained by two mechanisms: by passive diffusion of inward diffusion of chloride down its concentration gradient. So, sodium is a positively charged ion. To maintain the electroneutrality, chloride is also coming down the concentration gradient. And what happens more? By the regeneration of bicarbonate from the cellular CO2 and water in the presence of carbonic anhydrase. What will happen? Carbonic anhydrase will produce bicarbonate, and this chloride and bicarbonate will maintain the electroneutrality inside the cell. Now, through the basolateral membrane, what happens? In the basolateral membrane, the intracellular sodium is actively pumped out of the cell into the lateral intercellular space. Here energy is used. Okay. But what will happen? Free sodium is pumped out and 2 potassium comes in. By this method, by the sodium potassium ATP is pumped, about 67% of sodium reabsorption is done. The remaining one-third or 33% of sodium reabsorption occurs passively and paracellularly by solvent drag. How there is solvent drag? How? The efflux of sodium into the intercellular space creates an electrical gradient for the efflux of chloride and bicarbonate, which in turn generates an osmotic gradient for water transport into the intercellular spaces. The osmotic movement of water generates a small increment in hydrostatic pressure, and some bulk flow of water containing sodium chloride and bicarbonate proceeds into the peritubular capillaries. Okay, so you can see in the PCT, sodium reabsorption is a secondary active process. Both the bicarbonate is ATP is used, and it also occurs by passive movement. Now coming to the reabsorption of sodium in loop of Henle. Where does this loop of in the loop of Henle there is 3 segments. Okay, thin descending limb, thin ascending limb, and the thick ascending limb. In the thin segment of the ascending limb, thin segment here, here there is passive movement of NaCl. Okay, sodium is reabsorbed passively. Thin descending limb, it is impermeable to sodium. This portion is impermeable to water, but it absorbs NaCl passively. And in the thick ascending limb, thick segment, in this portion, sodium absorption is in the luminal side. There is a co-transporter or symporter. This symporter is known as sodium chloride potassium symporter in the luminal side. While on the basolateral side, the same ATPase pump is responsible, or there is active process. So you came to know that there is active absorption in the PCT, in the thick ascending limb. Now let's see what happens in DCT and CT. In the DCT and CT, only 18 to 20% of the filtered sodium is reabsorbed at the apical membrane. This involves two processes. There are two processes in DCT and CT. About 3/4, that is 75% of the sodium. 75% of the sodium that has been presented to the DCT is reabsorbed by chloride driven sodium transport. This is chloride driven sodium transport, and this absorbs about 75% of the sodium that has been presented to the DCT. The remaining 1/4 or 25% of the sodium is reabsorbed by two electrically linked cation exchange process. One exchange is via sodium is exchanged with potassium and sodium is exchanged with uh, hydrogen. Okay. Now this hydrogen and potassium are competes with each other for sodium exchange. Okay. These cation exchange processes are competitive, that is potassium competes with hydrogen for sodium and are enhanced, and this process is enhanced by aldosterone. Okay. So you have seen three processes present in sodium absorption. Secondary active transport is present. Secondary active transport means sodium is coupled with glucose and hydrogen in sodium is coupled with glucose and other amino acids in the in the PCT. Then in the basolateral membrane, sodium is transported to the interstitial space via the sodium potassium pump. Along with this there is a passive transport of the sodium also present in the PCT. What happens in the uh, loop of Henle? In the loop of Henle, sodium chloride potassium symporter is there in the luminal side, and on the basolateral side sodium potassium pump is active, and in the DCT and CT sodium is either it is reabsorbed by the chloride driven sodium pump or by the sodium potassium and hydrogen exchange. So you can see that sodium is coupled with potassium only in the loop of Henle and DCT and CT, but there is no role of potassium in the absorption of sodium in the PCT. Okay. Now, what are the factors affecting sodium reabsorption? First is the peritubular capillary hydrostatic pressure or colloidal osmotic pressure of the plasma protein. In this, if there is increased GFR, there will be increased natriuresis, or if you increase the extracellular fluid volume by how you will increase the extracellular fluid volume by increasing the intravenous infusion. If you increase the extracellular fluid volume, there is increased natriuresis. Effects of hormones responsible are the aldosterone and glucocorticoid. Aldosterone increase sodium absorption primarily in CT. There is no role of aldosterone in the PCT or in the loop of Henle. Glucocorticoids also increase natriuresis. Effects of other ions Any factor affecting sodium, potassium and hydrogen secretion will affect sodium absorption in the DCT and the CT. Why? Because sodium, potassium and hydrogen competes with each other for sodium reabsorption. Other factors that produce natriuresis are increased salt intake, prostaglandin E2, endothelin, and interleukin 1, and ANP. Now coming to the regulation of sodium excretion. How the kidneys regulate this sodium excretion? The amount of sodium filtered is so large that if total amount of sodium reabsorbed stayed constant, if you stayed constant, a small rise in GFR of only 2 ml per minute would result in sodium excretion more than double. Conversely, a small fall in GFR will reduce sodium excretion to zero. So, however, the total amount of sodium reabsorption is directly proportional to the GFR. That is, total amount of sodium reabsorbed rises when GFR rises and vice versa. Most of this change occurs in PCT. The tubule tends to reabsorb a constant fraction of the filtered amount rather than a constant amount. So this proportionality is referred to as glomerulo-tubular balance. So you understood that tubules absorb a constant proportion of the sodium and not the constant amount. How there is, if there is increase in GFR, what will happen? There will increase solute reabsorption in PCT. Then also there will be increased amount of sodium presented to the loop of Henle. This will increase the reabsorption there also, and finally more increased solute reabsorption in thick ascending limb of loop of Henle. Okay. Now, what are the pathologies in sodium reabsorption? In your higher classes, you will come to know about acute glomerulonephritis, nephrotic syndrome, hypokalemic alkalosis, and hypoaldosteronism. What are these? Acute glomerulonephritis is there is damage to the glomerular membrane. So, what will happen? There is excessive amount of sodium coming to the tubules and there is edema. What happens in acute glomerulonephritis? There is decrease in amount of sodium filtered. Okay. In the nephrotic syndrome, there is increase in aldosterone secretion and decrease in plasma protein. What is hypokalemic alkalosis? Due to chronic vomiting or hyperaldosteronism, there is increased exchange of hydrogen for sodium and then potassium for sodium. More of hydrogen gets excreted in urine, making the urine acidic and the plasma alkaline. What is hypoaldosteronism? There is decreased sodium reabsorption from DCT and decreased secretion of potassium and hydrogen causing hyperkalemia and acidosis. Okay. So you have to just learn the names of this pathology. Okay. Now rest of the portions we will be studying in our next class or tomorrow. What you had to do today is give the answer of what is renal splay and how, what are the differences in sodium reabsorption in different places of tubule. Okay, thank you.